I'm here to focus more on the radial tears. The commonest tear of these, commonest location for these tears is near the lateral meniscus, near the posterior root, which is commonly associated with the ACL injuries, as well as it is commonly seen in the meniscus body, where the body and the posterior horn junction is there. So we have to identify these tears on the thorough diagnostic ground. Before that, as it was highlighted in the morning talk, MRI, the sagittal images as well as the axial images through the meniscus does reveal these meniscus tears, and you have to watch for them. Usually they are not hidden because they are pretty obvious. The meniscus is going to be unstable. And once you have made a seen these tears on the MRI, we proceed on to have a diagnostic arthroscopic evaluation. So probing these tears is very important. At the times when you're encountering them late at 3 to 6 weeks, you can find a partial healing in these tears. But thorough probing will show that the depth of the tear, it is extending from the white zone to the red zone. And you can see that you should also look for the meniscocapsular separation of the anterior or the posterior leaf of these type of tears. So it is very important to repair these type of tears because excising them will lead to as good as a subtotal meniscectomy. Repairing these tears is important. And along with the suture biomechanics, providing a good biological healing potential is very important when you do with this type of tears. So there have been a lot of studies published in literatures, like we have seen in the past also, excising this meniscus. But there has been a more proposition for a radial tear or extrusion of the meniscus developing a higher risk of having knee osteoarthritis. So methods to repair this type of tears is an all inside meniscus repair devices can be used. We can also use a side-to-side stitch with the knee scorpion. We can also use inside out repairs at the body and the anterior junctions. Just one case example that I want to present. This is a 32 years gentleman with a 2 months history of trauma to the knee joint with pain and instability. Examination reveals Lachman's and Brower's test being positive. There is a McMurray's test which is positive and is often clicking in the joint which the patient complains of. The MRI reveals that there is a posterior horn. We have seen in details about the MRI assessment, but you can see a long oblique tear like this on the MRI, showing a tear at the posterior horn and the root junction. On a diagnostic arthroscopy, these tears would look like this. It is pretty obvious and straightforward that we can identify these type of tears. There may be associated secondary tears into the meniscus. Usually in the white zone, we end up excising them, but if a tear is extending right from the white zone to the red zone, it definitely needs a repair. Stimulation of the biology is very important. So we do abrasion with a diamond rasp, as well as an arthroscopic shaver can be used, which will debride the meniscus and the loose fragments. So in my setup, I usually do the ACL tunnels first and then go on to do these repairs to avoid manuring the knee joint during your tunnels. So I'm preferring here to do an all inside repair technique. So at the body and the near the body and the posterior horn junction, near the root junction, having a good bite into the meniscus is very important. Usually go 3 to 4 millimeters away from the tear margin in order to avoid cutout of the stitches. I had my equal share of cutouts of these type of techniques in the beginning phases, but gradually as you advance, you know how to take the stitch. A good bite in both the areas is very important. The penetration should be as posterior as possible to the meniscocapsular junction. I'm not worried about the further leftover tissue because after the approximation, you will see a nice contact between both the leaflets. Advantage of all inside devices is near the posterior horn and the root junction. At the body junction, you can use the inside out devices as well as the knee scorpion. I don't cut my stitch right away. I leave some tensioning to be done later on. Usually a 2 parallel stitch technique, horizontal mattress would do here. The first is a reduction stitch and then a detensioning stitch a little away from the reduction stitch. Care has to be taken that you don't, when you're taking the stitches, you don't come in the same path as the previous stitch, because you may at times cut through the previous stitch. Safe zones of the meniscus has to be kept into mind when you're doing this type of all inside devices. Lateral meniscus usually is pretty evident in a figure of 4 fashion, but the medial meniscus, as described in the previous talks, pie crusting is essential to see the entire depth. We may add on to a third crisscross stitch, which will start from the anterior edge to the posterior edge across the leaflets, or even two may do. We may add on one more third stitch, but I was happy with two of them. Knee scorpions makes your life easier at times where you want to reduce the cost of these all inside devices. This patient also had an ACL, so it went on to an hamstring ACL graft. Problem happens when you have a degenerated meniscus. So the meniscus, it's an old injury, neglected injury, and the meniscus shows signs of degeneration, as well as there is a significant parameniscal cyst formation. So this degenerated meniscus, there is an excellent technique which is described by Dr. Laprade, which shows that in addition to repairing this radial tears side to side, it is better that we anchor them to the tibial side with a transtibial tunnel technique, which will augment the biology also, as well as will stabilize the meniscus. So it has shown that the double cross vertical and the hybrid suturing techniques have shown to have better biomechanical stability. And the rebar repair has been introduced, which is very common now. To avoid to have a cutout, we use two vertical matrices and then two horizontal matrices to augment your repair. The superclot is essential, as we spoke about that stimulating biology. We can either do a superclot or we can use a microfracture in the notch, which will stimulate the healing of the meniscus. So the take-home message here is the radial tear repairs are a must, as excising it will lead to as good as a total meniscectomy. The double cross as well as the hybrid techniques lead to a better outcome. Does not matter what device you have, all inside, inside out, knee scorpion, or an outside in, best approximation is the aim. And augmented repairs are essential in isolated